This patient has microcornea, small pupil, coloboma iris, and a very hard grade 5 nuclear sclerotic cataract. Let us observe these minimally edited surgery. I have applied a superior rectus brittle suture because I may have to convert to SICS, though SICS is very difficult in this case because of microcornea and a huge nucleus. However, I am not going through the limbus, I want to go through the sclera. So I made a small peritomy at 11 o'clock, about half clock hours of peritomy. And now incision. Mild cautery was done, very mild cautery to have bloodless field of surgery. And now this is the incision, and then I took the crescent blade and made a sclerocorneal tunnel. So this is the main incision. This is a 2.8 millimeter incision, and now a side port is being made at around 8 o'clock. And now another side port is made on the left side of the main incision at around 2 o'clock. In this case, the pupil is small, it is dilated to some extent, but as soon as we start the surgery, as soon as we go inside the eye with phaco needle, the pupil will constrict. So my plan is to use 2 iris hooks, one at 10 o'clock, another on at 1 o'clock or 12:30 o'clock. An air bubble has been injected. Now this is the trypan blue dye to get some amount of contrast while doing Capsulorhexis. The cataract is dark brown and we are not getting any red glow in this case. So we need to get some contrast, at least a bit of contrast while doing Capsulorhexis. So the trypan blue 0.06% dye is injected. It goes under the air bubble. Little bit of adrenaline is injected, and then the dye is washed out. And now 2% hydroxypropyl methyl cellulose is used to fill up the anterior chamber. And now 2 small stab incisions are to be made. This one at around 10 o'clock and this one at around 12:30 o'clock. 2 small stem incisions for application of 2 iris hooks. Since this is a coloboma of choroid, we don't need to apply 3 or 4 hooks, just 2 is enough. Probably I could have used one more hook through the left side port for doing rhexis, and after doing rhexis I could have removed that iris hook. Given a second chance in future, I will keep in mind that probably one more hook through the left side port at 2 o'clock would have been better. Anyway, this is okay. Now I use this cystitome, a 26 gauge bent needle. A 26 gauge bent needle is being used to raise a capsular tag and see the wrinkling on the posterior capsule. Difficult to make a puncture on the anterior capsule. It means the total generalized zonular weakness. Now very gently start doing rhexis with the help of this utrata forceps. No jerky movements, but here at 5 o'clock it tends to go to periphery, and here at 3 o'clock it is under the iris. I could retrieve it, and here at 1 o'clock it came from under the iris to the area of visibility. Now hydrodissection become very tricky in this case. Zonule is weak and capsulocortical adhesions were strong. The nucleus was not getting separated from the capsule. I had to spend a lot of time in this part of the surgery. Actually, the whole bag is moving. As I tap the nucleus, the whole thing, the capsulolens mass goes down. So the nucleus doesn't get separated from the capsule. After a long time, it happened. Still I am struggling. Little bit of BSS is injected at multiple points. The nucleus is pushed gently, but it resists for movement. Whenever there is zonular weakness, when the capsulocortical adhesions are many, this happens. So we have to be patient, we have to hold a lot of patience to some steps of this kind of tough cases. Now I tried bimanual rotation, but as I went inside I found that the intraocular pressure is very low. Injected some visco, took the two hooks again, and tried to bimanually rotate it. Again I found that the intraocular pressure is very low. Injected some more visco. IOP appears okay. And now I took only one hook in my right hand, and I find that this time the nucleus is rotating. So ultimately, after 3-4 minutes of patient maneuvers, the nucleus is free from the capsule and it is rotating. Now before going into the eye with the Phaco needle, before introducing the handpiece, I want to use a capsular tension ring in this case. The patient is one-eyed, the other eye has been lost since birth, the other eye didn't develop. A very small cornea and the eyeball is very small, and the other eye didn't have any vision since birth. This is the only eye of the patient. So this is the capsular tension ring. It is also known as ECR, endocapsular ring. We call it CTR, capsular tension ring, as well as ECR, endocapsular ring. The CTR goes in, the leading end of the CTR goes towards 6 o'clock through the main wound. I'm holding it with the McPherson's forceps, and the tooth forceps is there in my left hand to support the other end of the CTR. The leading end has gone into the bag. Gently pushing it, it goes all around, and I have to place the other end, the trailing end of the CTR in the bag. Hold the trailing end with McPherson's, use a Sinskey hook, pass it through the eyelet and place it in the capsular bag. And now the bag is supported well all around, and I will have some, I'm relieved to some extent because the bag will not collapse. Zonular dialysis will be prevented to some extent. Still, I have to be gentle in my maneuvers. Bimanually rotating the nucleus, yes, it is rotating nicely. Ultimately, we have come to the point when we can introduce the Phaco handpiece in the eye. The antechamber is not deep, it is quite shallow, so we have to be careful. We must not apply ultrasonic energy in the aqueous. We must go inside the lens mass and then apply ultrasonic energy to protect the corneal endothelium. After going with bevel down, I turn the handpiece, make the bevel off, and now I bury the tip of the phaco needle into the substance of the nucleus, go through the substance for a distance. This is my submarine chop technique. Go through it for a distance, and after going for some distance, I try to chop the nucleus, and I could get a nice crack. I rotate. In this case, I didn't rotate on 180 degree. I rotated only 90 degree, and is making another crack. And now I rotate about 30 degree and make another chop. In this case, my plan is to make as many chops, as many cracks as possible, and ultimately I will get some free fragments. Otherwise, I can trim the edges of the pieces, and at last I can remove the central plate. The lens fibers are too leathery in this case. Yes, I got a small free fragment. I removed it. Making small pieces and trimming it from the periphery. The central part is attached to a central plate. Weak zonule and the posterior capsule will frequently tend to come to the aspirating port of the phaco needle. So we have to be very careful. This is one kind of peeling. I am keeping one layer always unemulsified to protect the posterior capsule. I am emulsifying a part of the nucleus and keeping a portion of the nucleus unemulsified just to protect the posterior capsule. And last, The IOL scaffold technique is must for this case. If I try to emulsify till the end, try to protect the posterior capsule with the chopper or any other technique, there is a possibility of catching the posterior capsule in this case. Patient is one-eyed, antechamber is shallow, microcornea, and with all these problems, I cannot afford to take any more chances. I came out, left a large chunk of the nucleus, and let me see if I can place the lens in the bag with this large chunk there. Yes, there is a nice cleft, big cleft. I can place the lens through this cleft in the capsular bag. The wound is adequate. Still, I may enlarge the wound little bit. The wound size was 2.8 millimeter, made it about 2.9 to 3 millimeter, so that I can deliver the lens at the right part. I can go inside with the cartridge. And here goes the cartridge. The chopper is supporting the lens mass. And here goes the lens. Leading haptic goes, and the trailing haptic nicely goes behind the ream, anticapsular ream, 12 o'clock. That means the lens is nicely in the capsular bag. And now I go in and emulsify this part of the nucleus without any fear in my mind that I will catch the posterior capsule. The intraocular lens occupies a large area. It supports the posterior capsule very well, and this is 100% foolproof way to protect the posterior capsule. Any other way, any posterior capsule protector, pushing the posterior capsule down with the blunt tipped chopper, all those things are not 100% foolproof. The foolproof 100% protection can be obtained only by this IOL scaffold. And now there is CTR and there is intraocular lens, and removal of cortex is the toughest part in such cases. I cannot pull the cortex centrally. I have to pull the cortex tangentially all around so that I can remove the cortex. Now I did hydrodissection for a long time, and the cortex is free. It is coming quite okay. I'm not getting a lot of trouble. So sometimes we are seeing white glow, that is because of coloboma of choroid. Sometimes we are seeing a bit of red glow, that is because the reflex is coming from the attached, from the part where there is choroid. Now I remove the iris hooks. For removal of the iris hooks, the silicone guard is drawn backward, and then the hook is advanced a bit, and then it is removed. So the two iris hooks have been removed, and now we are towards the end of this surgery. We are going to remove the visco now from the anterior chamber and capsular bag. So this is a bit of moxie, and this is hydration of corneal stroma for closure of the side ports. One may say that I could have done small incision cataract surgery in this case, but it was not easy. When the zonule is small and the cornea is so small and the nucleus is huge, SICS, at least to me, with my experience, SICS is tougher for me in this case than with all these precautions in Phaco. And now I oppose the conjunctiva with the releasable suture here. This is the small peritomy because I wanted to go through the sclera. I didn't want to go through limbus or cornea in this case. Just 3 loops and a releasable knot. This is least traumatic to tissues. Now we have reached to this point from this was the hard cataract. Now let us see some post-op pictures. This is the other eye of the patient. This eye has no perception of light, and this is the operated eye now after 48 hours. Very mild corneal edema, almost clear cornea, and the antechamber is quiet, intraocular pressure is normal, visual acuity is 6/36. Patient had this kind of vision before cataract, before she developed cataract. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. It will encourage you to improve your surgical skills and take up such challenging cases.